Welcome back to the Deep Dive. This is where we really get into the weeds, take those dense sources, and pull out what you actually need to know.
That's right.
And today, well, we're not just passive readers. We're stepping up. We're becoming, let's say, the ultimate research detectives. Skeptical ones.
Exactly. If you rely on research, and who doesn't these days, medicine, education, policy, even business,
Right?
then this deep dive, it's basically your essential toolkit.
It really is.
Yeah.
Because the core idea today, it feels a bit wrong at first, doesn't it? But it's so true.
It does. The idea that you just can't take published studies at face value.
Even the big names.
Even the big names, even those appearing in, the top tier journals. It's like that old saying, you just can't judge a book by its cover.
Or a study by its journal title.
Precisely. So we're setting out to really decode research quality.
And that's a challenge. Let's kick off with a classic scenario. The Nature publication paradox, let's call it. Imagine you're in a meeting, maybe reviewing research for a new policy, say a vaccine efficacy model, and someone pipes up very confidently. Look, it's published in Nature. It must be top quality. The results are solid. That carries a lot of weight.
Oh, absolutely. Huge weight. But the true skeptic, and that's what we want you to become,
Right.
that skeptic immediately thinks, hang on a second.
Yes, it's Nature, but.
Exactly. Yes, Nature, but did you actually look at the methods? The sample size is tiny, and look at the follow-up. It's really patchy.
So how generalizable can that really be?
That's the question. And that tension right there, the prestige versus the actual nuts and bolts, the methodology, that's exactly why we're doing this.
We are diving deep into quality assessment, or QA.
Yeah.
Specifically, how you use it within a systematic literature review, an SLR.
Our mission really is to give you the tools, the systematic methods to look at individual studies and figure out, is this actually any good?
So that when you pull all those studies together in your review, your final conclusion is solid. It's trustworthy. Demonstrably so.
We're moving past gut feelings, past just sort of, oh, that sounds plausible.
Yeah, no more of that. We're giving you a structured framework, standardized, to evaluate the design, the conduct, the analysis, basically the engine room of any research study you pick up.
Okay, before we properly jump into the how-tos, we really want to give a big shout-out and thank you
Absolutely.
to London Heartbeats Academy, UK. They've provided educational support for this deep dive, which is fantastic.
They're really committed to making high-quality knowledge accessible.
They are. And we seriously encourage you to check out their offerings. They've got over 150 popular courses, really useful stuff across tons of fields.
Definitely worth exploring.
And to stay in the loop, make sure you don't miss out on future discussions like this one. You really should subscribe to their social media.
Right, they're on Facebook, Instagram, YouTube. You get free regular updates. It's a great way to keep learning.
And one more thing, if you're looking to fast track your learning, maybe get some direct input.
You can upgrade your YouTube membership with them. That gives you early access to educational videos, and you can even get personal chats and guidance sessions.
Oh, wow. That's quite something. Direct access.
Yeah, pretty useful. Okay, so let's nail down why this QA stuff is so critical. Why is it absolutely non-negotiable in a proper SLR?
Well, our sources point to 5 sort of fundamental reasons. The first one is all about understanding.
Okay.
Doing QA forces you, really forces you, to get a much deeper grasp of the studies you're including. You go way beyond the abstract. You start to see the mechanics behind the results.
You understand how they got there,
Yeah.
not just what they found.
Exactly. Second reason, and this is super practical, QA lets you separate the wheat from the chaff. You can distinguish critically between good quality and poor quality studies.
And that decision point is huge for the whole review, isn't it?
It's everything. If a study is fundamentally flawed, you either have to toss it out or, at the very least, seriously downweight its findings. Otherwise...
The whole conclusion gets contaminated.
Right. Garbage in, garbage out. Which leads to the third point. Doing this rigorous appraisal massively increases the chance that your conclusions, the ones you draw from all the data, are actually meaningful, robust.
Makes sense. If the building blocks are solid.
The building stands up. Fourth, and this is a big bonus for you, the listener, the learner, doing QA, helps you develop critical appraisal skill itself.
Ah, like a meta skill.
Precisely. It's powerful. It makes you a better thinker, more skeptical, better at making decisions, not just in research, but everywhere.
Okay, and the fifth?
Fifth is about validation. Often, the quality of your entire SLR is judged using external checklists, And guess what?
QA's on the checklist.
QA is usually on this checklist. They want to see that you've assessed the quality of the individual studies to judge the quality of your review. It's an internal check that becomes an external stamp of approval.
Okay, that distinction between good and poor quality, point two. Let's make that concrete. Our first case example.
Yeah.
The misleading intervention.
Right. Let's imagine some education researchers publish a study. It's about a new classroom technique, maybe something gamified.
Sounds cool.
And the results look amazing. Huge jumps in math scores, headlines everywhere. Governments are thinking, wow, maybe we should roll this out nationwide.
Yeah.
Big money involved.
Okay, I can see where this is going. So you, the systematic reviewer, you pick up this study, you start the quality assessment.
And you look closely at the design. How did they actually do it? And bam, you spot a massive issue. Selection bias.
How so?
They didn't randomize the kids. Nope. They asked for volunteers for the special gamified group. And who volunteered, or rather, whose parents volunteered them?
Your keen ones.
The super engaged parents, the ones who are already helping with homework every night, attending every school meeting, maybe have more resources. They ended up in the intervention group.
And the control group.
Just the general school population, so the groups weren't comparable at all from the start.
Ah, so the amazing results.
Were probably not because of the fancy new technique. They were likely due to the pre-existing advantages and engagement of the kids in that group. That parental involvement, maybe socioeconomic status, those are huge confounders here.
The QA caught it.
Instantly. The reviewer realizes the success is just an artifact of bad design. So you dismiss that study, or at least give it almost zero weight in your review.
And the practical application.
You stop bad policy in its tracks. You prevent potentially millions being spent on an intervention that might not actually work for the average student because the evidence it was based on was flawed. That's the power we're talking about. Protecting resources, making sure decisions are based on real evidence. 2-second pause.
Okay, that really drives home the why. So now we need to get precise about the what, defining quality, and also when you do this assessment.
Right. So quality, it actually has two related meanings in this context. First up is the quality of the individual studies.
The building blocks again.
Exactly. And that's defined as the degree to which a study minimizes error and bias. Where? In its design, its conduct, and its analysis. It's all about internal rigor, minimizing mistakes and distortions.
Okay. Quality of the study itself, what's the second meaning?
That's the quality of the SLR itself, the overall review. And that's judged by checking your whole process against validated checklists. Did you follow all the steps correctly, including doing the QA of the individual studies?
Got it. So let's zoom in on the individual study quality. What does it really mean when we say this is a good quality study? It sounds simple, but you're saying it's a high bar.
It really is. It's not just a casual thumbs up. It means you've looked closely and you're genuinely confident that the way they designed it, ran it, and analyzed it, it was robust enough.
Robust enough to give results that are.
Results that meet three key criteria. 1, they're credible, believable in the scientific context. 2, they're trustworthy, the process was fair, unbiased. And 3, they're generalizable.
Meaning they likely apply beyond just the specific people in that study?
Right. Highly likely to be a true representation of what would happen in the wider population or with that phenomenon or that exposure being tested. If a study fails on credibility, trustworthiness, or generalizability, it's compromised.
Okay. Credible, trustworthy, generalizable. Got it. Now timing. When in the whole SLR process do you actually do this quality check? The sources mentioned before, during, or after data extraction.
Yeah, we can pretty much rule out during data extraction for the formal QA step. It usually doesn't fit there. So it's really a choice between before and after.
What's the case for doing it before you start pulling out the data?
You absolutely must do it before, if your plan, stated in your protocol, is to completely exclude studies that don't meet a minimum quality standard. You screen them out first, then extract data only from the good ones. Cleans the pool up front.
Makes sense.
Yeah.
But lots of people do it after data extraction, right? What's the argument there?
The argument is familiarity. They say, look, after I've spent all this time carefully extracting every detail from these studies, I know them inside out. Then I can answer those tricky QA questions more accurately with more nuance.
But there's a big risk there, isn't there?
Huge risk. It's called confirmation bias or maybe just investment bias. You've sunk hours, maybe days into extracting data from study X, you're invested. Then you do the QA and find out study X is actually pretty poor quality.
Uh-oh.
Subconsciously, you might downplay the flaws. You might rationalize them away because, well, you don't want to feel like you wasted all that effort. Your assessment becomes biased because you already did the extraction.
So your final report could be skewed.
Likely to be biased, yes. That's why, for maximum rigor, many argue it's better to assess quality independently, maybe even by different reviewers, and ideally before that deep data extraction dive. Keep it objective.
Okay, let's check if everyone's with us on this fundamental definition. Time for our first MCQ. MCQ 1. When defining the quality of an individual study for a systematic review, the primary focus is minimizing error and bias in which core processes? A. Acquiring funding and author credentials. B. Design, conduct, and analysis of the research. C. Maximizing the journal's impact factor. D. Using only commercially available validated instruments.
Okay, think about what we just discussed. The core mechanics. The answer is B, design, conduct, and analysis.
Right. Quality is about the engine room, how the research was actually planned, run, and interpreted. Not the funding, not the journal prestige. It's the methodology. 2-second pause. All right, we've defined quality and timing. Now we get into the nitty-gritty. Section 3. The 10 deadly sins of research.
Ooh, dramatic. But yeah, that's basically what they are. If QA is like an audit, these 10 things are the major vulnerabilities, the ways a study can go wrong and basically invalidate its findings.
And the QA tools we'll talk about later, they're designed to sniff out these specific sins, these biases.
Exactly. They're instruments built to assess the risk of these biases being present. Our source material lists 10 key elements, and many frameworks, like the UNET TA one mentioned, flag these as critical threats. If a study bombs on these points, well, it stops being solid evidence.
Okay, let's break them down. Where should we start?
Let's start with the two big ones that determine who gets into the study and where they go. Selection bias and allocation bias.
Right.
First, selection bias. The core question here is the sample you're studied actually representative of the bigger population you want to talk about?
The ducks example from the source is good here.
Yeah, the ducks. Imagine your population is a mix of gray, blue, and yellow ducklings. But for your study, you somehow only end up picking the gray ones. Your sample is clearly not representative, right?
Right, and the significance.
It kills generalizability and transferability. If your study on a new teaching method only included kids from affluent schools, you simply cannot generalize those findings to kids in under-resourced schools. It doesn't transfer. Same if it only included men. You can't just assume it works for women.
Okay, that's who gets in. What about allocation bias?
Allocation bias is about what happens next. How do those selected participants get assigned to the different groups, like the treatment group versus the control group?
Is it random, or is there some meddling?
Exactly. Any human influence, any non-random factor interfering with who goes where introduces allocation bias. The strength of the whole study design really hinges on this. Random assignment, like flipping a coin for each person, is the gold standard because it removes that human element.
But if a researcher can, maybe even subconsciously, steer certain participants,
Yeah.
like putting the ones they think will do well into the new treatment group.
The study is biased from the get-go, before the treatment even starts. The comparison isn't fair.
Okay, let's pause for another check-in, MCQ 2. What is the primary methodological consequence of significant selection bias in a research study? A, it increases the cost of the intervention. B, it directly impacts the generalizability and transferability of the results. C, it prevents any outcome data from being collected. D, it only affects retrospective study designs.
Think about the ducks. What did the non-representative sample affect? The answer is B. It hits generalizability and transferability.
Correct. Selection bias means your sample doesn't mirror the target population, so you can't confidently apply the results more broadly.
Okay, next up. The two blinding biases. These are all about who knows what. First is performance bias.
Performance.
Yeah.
Like how people behave.
Sort of. It asks, is anyone aware of who's getting which treatment? This could be the participants themselves, the doctors or nurses giving the treatment, or even the main study investigators.
And why does that matter?
Because awareness changes behavior. If you know you're getting the exciting new drug, not the placebo, you might unconsciously try harder, report feeling better, pay more attention. It's the placebo effect, or sometimes the Hawthorne effect, just being watched changes things.
So it skews the results,
Yeah.
making the intervention look better than it might actually be.
Precisely. Now, related to that is detection bias. This is also about awareness, but specifically focuses on the people measuring the outcome.
Ah, the assessors.
Right. Are they aware of which group the participant was in? If the person measuring, say, tumor size on a scan knows this patient got the fancy new therapy, they might subconsciously look a little harder for shrinkage or interpret a borderline result more favorably compared to someone they know got the placebo.
So it biases the actual measurement process itself.
Yes.
Yeah.
It compromises the objectivity of the data collection. Blinding the outcome assessors is crucial for objective measurement.
Okay, blinding is key. What's next on the sin list?
Let's talk about dropouts. Attrition bias. This looks at how many participants stopped participating before the study ended, either because they chose to leave or were withdrawn by the researchers.
People dropping out happens, though.
It does. But two things matter. First, high dropout rates overall can weaken generalizability. Maybe only the really motivated or healthy people stuck with it, but the real killer is when the dropout rates are different between the groups.
Differential attrition.
Exactly. Imagine 50% of people on the new drug drop out because the side effects are terrible, while only 5% drop out of the placebo group. What does it tell you?
Well, the people left in the drug group are the ones who could tolerate it. They're not representative anymore.
Right. And the comparison with the control group is now totally meaningless.
Yeah.
The groups are no longer balanced like they were at the start. Attrition bias, especially differential attrition, can completely wreck a study's validity.
Let's test that. MCQ 3. If a new drug trial sees a 40% dropout rate in the treatment group due to severe nausea, while the control group only sees a 5% dropout rate, this differential withdrawal primarily introduces which type of bias? A. Funding bias. B. Attrition bias. C. Performance bias. D. Analysis bias.
Focus on the dropouts being unequal. That's classic B, attrition bias.
Correct. The unequal dropout rates destroy the comparability of the groups remaining at the end.
Moving on to research integrity. Reporting bias. This one's sneaky.
How so?
It's about selective reporting. The study protocol might say they plan to measure 5 different outcomes, but when the paper gets published, they only report the 2 outcomes that showed a positive, statistically significant result. The other 3, maybe they showed no effect or even harm.
They just get quietly dropped.
Exactly. Or sometimes researchers might measure extra outcomes after seeing the initial results, post-hoc analysis, specifically looking for something positive to report.
That sounds really misleading.
It is. It makes the intervention look much better or safer than it really is. You, as the systematic reviewer reading the published paper, might not even know about the outcomes that weren't reported unless you can find the original protocol, maybe on a registry like clinicaltrials.gov. It's a major challenge.
Okay, hiding the bad news. Got it. What about confounders? We touched on this with the education example.
Right. Confounding is huge, especially in non-randomized studies. The question is, are the groups being compared similar in all the important characteristics at the start of the study? We're talking age, gender, health status, income, lifestyle factors, anything that could also influence the outcome.
So if the group getting the new heart drug also happens to be, on average, 10 years younger and exercises more than the control group.
Then if they have better outcomes, you can't be sure if it was the drug or their youth and fitness. Age and exercise are confounders here. They confuse the relationship between the drug and the outcome. Good studies need to measure and control for potential confounders.
Let's check understanding on that one, MCQ 4. In a retrospective cohort study examining coffee consumption and heart disease, if the control group, low coffee drinkers, inadvertently contains a significantly higher proportion of participants who are heavy smokers compared to the high coffee drinkers, what threat does smoking pose? A. Detection bias. B. Allocation bias. C. Performance bias. D. Confounder.
Smoking is a separate factor that influences heart disease, and it's distributed unevenly. That makes smoking a classic D confounder.
Exactly. It's a third variable messing up the apparent link between coffee and heart disease.
Okay, nearly there. Just 3 more sins. Number 8 is concurrent or subsequent intervention.
Meaning other treatments happening at the same time.
Yeah. Besides the specific intervention being studied, did participants receive any other treatments? Ideally, both the intervention and control groups should be treated exactly the same way, except for the intervention itself.
Why?
Because if, say, the control group starts taking some other effective medication off-label or gets extra therapy sessions the researchers don't know about, it could improve their outcomes.
Which would make the study intervention look less effective than it really is.
Right. It masks the true effect. You need to ensure similarity of all other care provided.
Makes sense. Number 9.
Analysis bias. This is about who gets included in the final number crunching. Specifically, were the data for all participants included in the analysis, even the ones who dropped out or didn't stick to the treatment perfectly?
This sounds like that intention to treat idea.
Exactly. Intention to treat ITT analysis is the gold standard. It means you analyze everyone based on the group they were originally assigned to, regardless of what happened later. You analyze them as intended.
What's the alternative?
The alternative is often called per-protocol analysis, where they only include the data from people who perfectly completed the study according to the protocol.
But that introduces bias, right? Because the dropouts or non-completers are usually different.
Yeah.
Maybe the treatment didn't work for them or they had side effects.
Precisely. Excluding them makes the results look artificially rosy. ITT analysis gives a more realistic picture of what happens when you try to implement the intervention in the real world, dropouts and all. Analysis bias creeps in when you selectively exclude data.
Okay, analyze everyone you started with. And the final sin, number 10.
Funding bias. Simple question. Who paid for the study?
Follow the money.
Basically, yes. Does the funder have a vested interest in the outcome? Particularly with industry funding, there's always a potential risk, conscious or unconscious, that the study design, the analysis, or how the results are reported might be swayed to favor the funder's product or interest.
It doesn't automatically mean the study is biased.
Not at all. But it means you, as the critical appraiser, need to be extra vigilant. Look even more closely at the methodology, the reporting, the potential for those other 9 sins when there's a clear financial interest involved. Transparency is key.
Okay, 10 deadly sins. Let's tie a couple together with our second case example, the allocation trap. We're looking at allocation bias and confounders here.
Right. Imagine a government wants to test a new program to boost financial literacy in low-income communities. Good goal. But instead of randomly assigning people, they just set up stalls in community centers and ask for volunteers to join the special program group.
Okay, volunteer.
Who volunteers for a financial literacy program? Probably people who are already a bit more motivated, maybe slightly better organized financially, more proactive about seeking help compared to the average person in that community who doesn't volunteer.
So that's allocation bias right there. The groups are formed non-randomly based on who steps forward.
Exactly. And that immediately creates confounding. The volunteer group starts off different from the non-volunteer comparison group. They have higher baseline motivation, maybe better existing skills. These are confounders.
So when this study finishes and finds the volunteer group has better financial outcomes.
The reviewer doing QA has to ask, was it really the program, or was it mostly because these motivated people were likely to improve anyway? The allocation method created groups that weren't comparable, and those baseline differences, confounders, likely drove the result.
So the finding about the program's effectiveness is shaky.
Very shaky. The quality assessment flags this. It prevents policymakers from potentially rolling out an expensive program based on results that were really just measuring the motivation of the volunteers, not the program's true impact on the target population. That interaction between bad allocation and confounding is lethal to validity. 2-second pause.
Okay, we've got the why QA is vital and the what those 10 biases to look for. Now, section 4, putting it into practice. The systematic steps and how study design is king.
Right, we're circling back to the 6 core steps of doing QA within an SLR. Step 1, we said, is foundational. Note the design of your included studies. You absolutely have to classify each study first. Is it an RCT, a cohort study, case control, something else?
Because that classification dictates everything that follows, right?
Everything. It leads straight into step 2. Identify the type of QA tool that fit those designs. And step 3, choose the specific appropriate QA tool.
Then you actually use the tool.
Step 4, carry out the QA using that chosen tool. Step 5, tabulate and summarize what you found, the scores, the key weaknesses.
And the final crucial step.
Step 6, think about how those QA results impact your overall conclusions and recommendations for the whole SLR. Does the poor quality of evidence change what you can confidently say?
Let's really hammer home that point from step 1 leading to step 2 and 3. Why is the study design the only thing that should guide your choice of QA tool? Not the topic, like cancer or education.
Because different designs have different inherent weaknesses. They are susceptible to different deadly sins. A tool built for an RCT will ask detailed questions about randomization and blinding things that are central to an RCT's quality.
But those questions are irrelevant for, say, a case control study.
Completely irrelevant. For a case control study, the critical questions are about how well the cases and controls were selected, were they comparable, how accurately was past exposure measured, were confounders controlled. An RCT tool wouldn't even ask those questions properly. You'd miss the most important potential biases.
So you need a tool tailored to the design's specific vulnerabilities.
Precisely. Which brings us neatly to the levels of evidence, or the hierarchy of study designs based on their inherent strength against bias.
The evidence pyramid.
That's the one. At the very top, the peak, giving the highest strength level 1 evidence, you find the randomized controlled trial. RCT. And ideally, meta-analyses that pool results from multiple high-quality, similar RCTs.
And why are RCTs level 1?
Because they use those two magic ingredients: randomization to create comparable groups, and control groups for a fair comparison. These features are the best defense we have against selection bias and allocation bias and help manage confounding.
Okay, below the peak.
Level 2 typically includes prospective cohort studies. These follow people forward in time, comparing outcomes between an exposed group and a non-exposed group. They often have control groups but lack randomization, making them more vulnerable to confounding. Meta-analyses of level 1 or 2 studies with mixed results might also fall here.
Then level 3.
Level 3 often houses retrospective cohort studies and case control studies. These designs often look backward in time or have less robust ways of ensuring group comparability at the start. Again, meta-analyses of level 3 studies would be here too.
And the base of the pyramid.
Down at levels 4 and 5, you get much lower strength evidence. Case series, level 4, just describe experiences of a group of patients with the same condition or treatment. Below that, level 5 includes things like individual case reports, expert opinion, or just personal observations.
Useful for ideas maybe, but not strong evidence for cause and effect.
Exactly. They have minimal control over bias. The whole hierarchy is fundamentally built on how well the design controls for bias, particularly through randomization, use of controls, managing sample size, and ultimately supporting generalizability.
Time for an MCQ on that hierarchy. MCQ 5. Why does the randomized controlled trial, RCT, sit atop the hierarchy of evidence constituting level 1 evidence strength? A, because it is the cheapest study to run. B, because its use of randomization and control groups effectively minimizes selection and allocation bias. C, because it always has the largest sample size. D, because it is the oldest form of research design.
Think about those two key features of an RCT. The answer has to be B. It's the randomization and control groups tackling bias.
Correct. That methodological rigor is what gives it the top spot. Cost, sample size, and age of design aren't the primary reasons for its level 1 status.
Okay, maybe it helps to quickly visualize the main designs we're talking about assessing.
Good idea. Let's picture them. First, the RCT.
You start with your defined population. Key step. You split them into the intervention group and the control group purely by random chance, like flipping a coin or using a computer generator. That randomness is vital. Then you apply the intervention to one group, not the other, and measure the outcomes in both.
Okay. What about non-randomized studies, NRS, generally?
Here, the split into exposed and not exposed, or treatment versus control, happens based on something other than pure chance. It could be patient choice, doctor's decision, where they live, existing practices. It's not random. These often require careful statistical adjustment to try and handle the inherent biases.
Got it. Now, specifically cohort studies.
Think of a cohort as a group followed over time. In a prospective cohort study, you identify your groups now, say smokers and non-smokers, based on their exposure status, and then you follow them forward into the future to see who develops lung cancer, present to future.
And retrospective.
A retrospective cohort study still looks at exposure leading to outcome, but uses past data. You might start today, use medical records from 1990 to identify who was a smoker and who wasn't back then, the cohort and their exposure, and then track their health records forward from 1990 up to today to see who developed lung cancer. Using past records, but still conceptually moving from past exposure to later outcome.
Okay. How does that differ from a case control study?
Case control flips the logic. It starts with the outcome. You identify people who already have the disease, cases, which are people with lung cancer. Then you find a comparable group who don't have the disease, the controls. The crucial step is then looking backward in time for both groups, using records or interviews, to figure out their past exposure status. Figgy, were they smokers or not? You're comparing past exposures between those with and without the disease, outcome back to exposure.
That backward look is the key difference. Let's check that. MCQ 6. A study begins by identifying all individuals diagnosed with lung cancer cases within a hospital system and compares their past smoking habits to a matched group of healthy individuals. Controls. What is this design called? A. Prospective cohort study. B. Randomized control trial. C. Case control study. D. Cross-sectional study.
Starting with the outcome, cancer, and looking back at exposure, smoking, that's definition C, a case control study.
Correct. Working backward from outcome to exposure.
And just quickly, those lower levels. A case series or case report is simpler. You just describe what happened to one person, report, or a small group series who all received a similar treatment or had a similar condition, No comparison group usually.
More descriptive than analytical.
Right. And finally, the cross-sectional study. Think of this as a snapshot. You take a sample of a population at one single point in time and measure both exposure and outcomes simultaneously, like a survey asking people today about both their diet and their current blood pressure.
So it tells you about prevalence, but not really cause and effect over time.
Exactly. No follow-up period. You see associations at that moment, but can't easily tell which came first.
2-second pause.
Okay, we've got the designs mapped out. That leads us directly into Section 5, the QA toolbox. We're now hitting steps 2 and 3, identifying the type of tool needed, and then choosing the specific tool. Right. And the key message here, again, is that there's a whole range of tools out there developed by different groups over the years. The UNEFT T-Source, for example, lists quite a few. But your choice has to be driven by the study designs you found in Step 1.
Let's look at some of the big players mentioned in the sources.
Yeah.
Which tools are versatile?
Well, the Robins-Eye tool that stands for risk of bias in non-randomized studies is a really comprehensive one from the Cochrane collaboration. Despite its name focusing on NRS, it's actually designed to be applicable, with some adaptation, to both non-randomized studies and RCTs. It's quite detailed, 20-something items.
Okay, Robin's Eye over potentially both. What else?
The Downs Black checklist is another one often cited as being applicable to both NRS and RCTs. Same for the Miners Tool Methodological Index for non-randomized studies. Although its name clearly points to its primary focus, it can sometimes be adapted.
But the real clarity comes with the specialized tools, right?
Exactly. For non-randomized studies, specifically cohort and case control studies, the go-to tool is often the Newcastle-Ottawa Scale, or NS. It's explicitly designed for them.
And only 8 items, the source says. Seems more manageable.
Relatively, yes, though each item requires careful judgment. Another one specifically for NRS is Robin's Risk of Bias Assessment tool for non-randomized studies. The sources also list others like CSP checklists, EPHPP, GRACE, each with specific applications and item counts.
So if your SLR is full of cohort and case control studies,
Yeah.
MCQ 7, you are conducting an SLR that focuses solely on the long-term effects of environmental exposures, leading you to include only case control and retrospective cohort studies, NRS. Which quality assessment tool is most specifically designed and commonly used for your review? A, the Cowley checklist, often for public health. B, the specialized consort checklist, which is for RCTs. C, Newcastle-Ottawa Scale, NOS. D, Prisma checklist, which is for reporting the SLR itself.
Focusing on NRS designs like cohort and case control, which tool fits best? That would be C, the Newcastle-Ottawa Scale, NOS.
Correct. While others might apply, NS is the specialist tool for these specific non-randomized designs.
Now, just choosing a tool isn't the end of it. You need to understand what biases it actually covers. The source material has that really useful table showing bias domain coverage.
Right, comparing tools side by side. What are the main domains shown?
The table typically highlights coverage for the big ones: confounding, selection bias, performance bias, blinding of participants' personnel, detection bias, blinding of outcome assessment, attrition bias, and reporting bias. Sometimes confounding and selection are split into subdomains, leading to maybe 6 or 7 columns.
And the symbols tell the story. Solid circle, open circle, dash.
Exactly. Solid black circle means the tool is designed to fully assess that bias domain. An open circle means it's only partly covered, maybe implicitly or with just one question. And a dash means...
It doesn't cover it at all.
Right. The tool simply ignores that potential bias, and this is where you see major differences.
Give us an example.
We'll take the NOS, our go-to for cohort and case control studies. According to that table logic, it usually gets solid circles for selection, confounding, detection, and attrition. It assesses those quite well. But it often gets dashes for performance bias and reporting bias. It typically doesn't have specific questions about whether participants or personnel were blinded or whether all outcomes were reported.
Ah, so if you were reviewing, say, drug trials where you strongly suspect selective reporting might be an issue.
Relying only on the NOS might leave a significant blind spot in your quality assessment. You might need to supplement it, or choose a broader tool like Robin's Eye if appropriate for the designs, which generally aims for wider coverage across these domains. No single tool is perfect for every single bias in every situation.
Okay, understanding the tool's limitations is key. Let's check that interpretation. MCQ 8. If you are using a quality assessment tool and the coverage table provided in your resources shows a solid black circle next to the domain performance bias, what does this indicate? A, the bias is not relevant to the tool. B, the bias domain is fully covered by the tool's questions. C, the bias is only partly covered. D, the bias is only covered in RCTs using this tool.
Solid black circle means. That indicates B, the bias domain is fully covered.
Correct. Solid circle, comprehensive assessment for that specific bias.
Okay, so we've chosen our tool based on design. We understand its coverage. Now we're at step 4. Carry out the QA. Let's use the NOS as our detailed example since it's so common for observational studies.
How does it work? The STAR system.
Yeah, the NOS uses a star system to score studies. Depending on whether you're using the cohort or case control template, the maximum score is typically 9 stars. It assesses quality across 3 main sections.
Section 1.
Selection. This looks at how the study groups were formed. For a case control study, it asks. Were the cases clearly defined and diagnosed reliably? Were the controls truly representative of the population the cases came from? For a cohort study, was the exposed cohort representative? Was the non-exposed cohort drawn from the same community? How was exposure ascertained? You get stars for robust selection methods.
Okay, ensuring the right people are in the right initial groups. Section 2.
Comparability. This is arguably the most crucial section for non-randomized studies. It asks, did the study control for the most important potential confounders? Did they control for any additional relevant confounders?
And this is where the weighting comes in.
Exactly. This is the only section where a study can earn up to 2 stars. 1 star for controlling the main confounder, and a 2nd star if they also controlled for other key factors. This double weighting highlights just how critical controlling for confounding is to the validity of NRS.
That makes perfect sense. 2 stars for comparability, because that's the biggest challenge. Let's quiz that. MCQ 9. When scoring a study using the Newcastle-Ottawa Scale, NOS, why is the comparability domain given a maximum potential score of 2 stars, unlike most other domains which award a maximum of 1? A, to reward studies with large sample sizes. B, because controlling for confounding is considered the most critical validity threat in non-randomized studies, thus warranting higher weight. C, because comparability is easier to measure accurately. D, this 2-star system only applies if the study used statistical matching.
Why the extra emphasis on comparability? The answer is B. It reflects the critical importance of managing confounders in non-randomized designs.
Precisely. Okay, comparability gets up to 2 stars. What's the third NOS section?
The third section is about measuring the key variable of interest. It's called exposure in the case control template and outcome in the cohort template.
What does it check?
It looks at how reliably the exposure for case control or the outcome for cohort was assessed. Was it done through secure records? Was it self-report? Crucially, for cohort studies, was the outcome assessment done blindly? Did the assessors know the exposure status? Was the follow-up long enough? Was it complete enough, i.e. low attrition? You get stars for high-quality, reliable measurement and follow-up.
Okay, so you go through selection, comparability, exposure outcome, awarding stars based on the criteria. That completes step 4. What about step 5?
Step 5 is tabulate and summarize results. You create a table, maybe like the example template shown in the source for case control studies, listing each included study down one side and the N criteria, or star counts per section total, across the columns.
So you get clear visual overview.
Exactly. You can see at a glance which studies scored well overall, maybe 7, 8, 9 stars, which ones scored poorly, where were the common weaknesses, did lots of studies fail on comparability, or was follow-up the main issue. This table makes the quality landscape visible.
And that table directly feeds into the final steps. Let's illustrate that with our final case example, the star score difference.
Okay. Let's say your SLR is looking at the link between working night shifts and developing metabolic syndrome. You're mainly finding cohort studies, so you use the NS.
Right.
You assess study A. It followed nurses for 10 years, good exposure data on shift work. But when you look at comparability, they only controlled for age and sex. They completely ignored crucial confounders like diet, exercise levels, smoking, things known to affect metabolic syndrome.
So low stars for comparability.
Very low. Maybe only 1 star there. The total NS score for study A ends up being, say, 4 out of 9 stars. Pretty weak.
Now you assess study B. Similar design, maybe slightly smaller, but they used sophisticated methods. They collected detailed data on diet, exercise, smoking, family history, socioeconomic status, and they statistically adjusted for all of these in their analysis.
So they get the full 2 stars for comparability.
Yes, and they also did well on selection and outcome assessment. Study B scores a strong 8 out of 9 stars.
No, the tabulation makes the difference stark. Study A, 4 stars versus study B, 8 stars.
Exactly, and this quantified difference is crucial for step 6. You cannot just average the results of study A and study B or treat them as equally valid evidence. The star scores tell you study A's findings are at high risk of being biased by confounding.
So what do you do? You have options defined in your protocol. Maybe you set a quality threshold beforehand and exclude study A entirely. Or, more commonly in meta-analysis, you give study A much less weight in the final pooled result. Its 4-star contribution counts far less than study B's 8-star contribution. The QA score directly influences the final conclusion about the link between shift work and metabolic syndrome.
The quality assessment isn't just a score, it actively shapes the synthesis.
That's its entire purpose.
Okay, one last MCQ to check the sequence of these steps. MCQ 10. In the systematic process of conducting quality assessment within an SLR, which step logically and immediately follows step 4? Carry out QA using the appropriate tool. A. Note the design of the included studies, step 1. B. Think about how QA results impact conclusions, step 6. C. Identify the type of QA tool, step 2. D. Tabulate and summarize results of your QA, step 5.
After you've done the scoring with the tool, what's next? You need to organize those scores. So it's D, tabulate, and summarize the results.
Correct. Step 4, doing the assessment, leads directly into step 5, summarizing what you found.
Yeah.
2-second pause. We've journeyed through the whole process, from the why to the how. Now we land firmly on the final, most critical step, the payoff. Step 6. Think about how your QA results might impact on the conclusions and recommendations of your SLR.
This is where it all comes together. The scoring, the tabulation, understanding the biases. It wasn't just an academic exercise. It has real consequences for what you can actually claim at the end of your review.
So if your careful QA reveals, let's say, that most of the studies on a particular therapy are actually pretty low quality, maybe they consistently scored low on the NS for comparability or had high attrition bias,
then your conclusion cannot be overly strong or definitive. You can't just say therapy X is highly effective. You must qualify it.
how would that sound?
You'd need to write something like, the available evidence suggests therapy X may offer some benefit, however. The overall quality of the included studies was assessed as low, primarily due to a high risk of confounding and attrition bias. Therefore, these findings should be interpreted with caution.
Honesty about the limitations.
Absolutely. And it does two things. It gives users of your review, clinicians, policymakers, an accurate picture of the certainty of the evidence. And it signals where future research efforts should focus. We need better quality studies, studies that address these specific methodological weaknesses.
So QA isn't about grading papers for the sake of it. It's about ensuring the final recommendations are genuinely evidence-based and appropriately cautious.
That's the entire goal. Trustworthy conclusions demand quality assessment.
Okay, let's wrap this deep dive up by consolidating the absolute must-remember points, our top takeaways.
Takeaway number 1, skepticism is mandatory. Don't be fooled by fancy journal titles or big author names. Become that research detective. Critical appraisal isn't optional, it's essential. Quality is about method, not reputation.
Takeaway 2. Quality defined by rigor. Remember, quality means minimizing error and bias in the study's design, conduct, and analysis. The goal is results that are credible, trustworthy, and generalizable.
Takeaway 3. Know the 10 deadly sins. You need to be actively looking for those major biases: selection, allocation, performance, detection, attrition, reporting, confounding, concurrent intervention, analysis, and funding bias. They are the common enemies of validity.
Takeaway 4. Design dictates the tool. Always choose your QA instrument like NOAA, CASP, based on the study designs you're assessing. RCT, cohort, case control, not the topic. Different designs need different checks.
Takeaway 5. Hierarchy matters. Understand the levels of evidence. RCTs are at the top because randomization and control groups offer the best defense against key biases. Lower levels have less control, meaning higher inherent risk.
And takeaway 6. Quantify and use the risk. Tools like the NOS don't just identify potential bias. They help quantify the risk, often with scores or ratings. Use this assessment actively in Step 6 to weight studies appropriately and shape your final conclusions. Don't just report the scores. Let them influence your synthesis.
Those 6 points really capture the essence of rigorous QA.
They do. And now, for our final provocative thought to leave you with.
We spent this whole time talking about how common these flaws can be: selection bias, reporting bias, confounding, so common that we have entire checklists designed just to catch them, even in published research.
So consider this. How many decisions in your everyday life or in society at large, decisions about medical treatments, financial strategies, educational policies, maybe even political choices, how often are these based on evidence or studies where the conclusions might have been subtly or not so subtly skewed?
Skewed by poor design, by selective reporting, by unacknowledged funding bias. If these flaws are pervasive even in research that makes it to publication, how much flawed information might be shaping critical choices without us even realizing it?
The power you've gained today, understanding critical appraisal, isn't just academic. It's the power to ask better questions, to demand better evidence, and ultimately to make more genuinely informed decisions in a world saturated with information, not all of it trustworthy. It's the power to see past the surface.
Well put. It's about demanding rigor.
Thank you for joining us on this deep dive into the critical world of quality assessment. We hope you feel better equipped to be that research detective. We'll catch you next time on The Deep Dive.